Hi, everybody. Welcome to the Breast Cancer Task Force educational series. I wanted to remind everybody there is Spanish translation available. So if you want to hit the globe in Zoom to English or Spanish, feel free to do that. Next slide, please. This is the Breast Cancer Task Force. Our mission is to reduce the impact of breast cancer for Coloradans through risk reduction, early detection, access to personalized cancer care, and comprehensive survivorship support, regardless of social determinants of health, geography, or personal community identity. Next slide. I will introduce our speaker today. Mr. Dennis Wright II is the lead cancer epidemiologist in the Center for Health and Environmental Data at the Colorado Department of Public Health and Environment. His primary roles are to monitor cancer screenings across Colorado and provide data analytical support to 5 CDPHE programs, 3 of which are in the Prevention Services Division, including the Women's Wellness Connection. Dennis received his Master of Public Health degree in epidemiology from the Colorado School of Public Health and his Bachelor of Arts degree in Public Health from the University of Colorado at Denver. Dennis also has a background in both health and data equity and leads topic-driven discussions about social epidemiology. Prior to his public health career, Dennis spent 15 years in the biotechnology sector, most recently as manufacturing quality engineer at Pfizer. In his downtime, Dennis enjoys spending time with his wife and 2 children, taking on new woodworking DIY projects, solving all manner of puzzle games, and making time to enjoy a good laugh with anyone. Thank you so much, Dennis.
Thank you. And thanks everyone for having me here. As we mentioned, my name is Dennis, and I get to talk with you about what breast cancer looks like from the numbers perspective around Colorado. Whoops, how about I go the other direction? That'll work. So just to start us off, within the last few years, as you can see here, breast cancer was the third leading cause of death. And around the same time, it was the most commonly diagnosed cancer out of the top 10 for both men and for women. I will make a quick note that the language using here, especially the sex and gender language, it's going to reflect the data sources that we're covering through today. And the numbers will include both males and females unless we otherwise specify. So we'll start by talking about breast cancer incidence. And I don't know where everybody is in their data journey. So if I speak way over your head or way below your pay grade, I apologize in advance. Just trying to reach as many people as possible. So for instance, you can think of this as basically the new breast cancer cases that developed over a given time period. And for that, we're looking at 2022, where we had just under 4,700 new breast cancer cases here in Colorado. But what I found more interesting is about 45% of all the cases that year were just in these 4 counties. That left 55% in the other 60 counties that we have here in our state. So quite interesting. Um, Also to note, there's sometimes a perception that cancer is an old person's disease, quote. But in fact, it can touch us at pretty much any other age group. Though it is true that you will develop, you do end up with a higher risk over time. So as we get older. So what we do when we're measuring these, we try to level the playing field age-wise, trying to standardize things. And what we'll report next is called the age-adjusted rate. So here's how it works. If we were to pick 100,000 Coloradans that year, 69 of them will have been diagnosed in 2022. So it just kind of gives you a nice flat single number you can report. Now compare that to the year before, we had 1 more person. And the year before that, we actually had 5 fewer people. So there's a bit of up and down you'll see. And I want to demonstrate that by showing you this next chart. It is a little harder to read, acknowledging that. So I wanted to point out 3 main things here. So the highest rate we had when we started reporting this in 2000 is we had 73 per 100,000. But notice 4 years later, we actually have 11 fewer new cases, which is a good thing. We want this rate to continue to go low. And then you see it kind of stabilizes for a while. We get to our second lowest in 2022, but then it shoots back up, excuse me, in 2020, and then it shoots back up in 2021. Now, there's good chance that there's what we kind of dubbed the COVID effect involved here, though we have not actually done research to say that definitively. The good news is this is a survivable cancer, and one of the ways we talk about it is after 5 years, how many people that were diagnosed are still with us 5 years and beyond. And so what we found in this admittedly a little old data that was most recently available to me, um, we saw that if you were at stage 2, localized, 92% of those diagnosed at this stage would survive 5 years or longer. Moving on to the regional, you see it goes down a little bit to 84. And by the time you get to the distant stage, it's it kind of goes with the floor where only a third of people here would survive 5 years or more. But collectively, through all stages, you can have a survival rate of about 87%, which that is, I find that to be more encouraging than for some other cancers. But we also have to be mindful that not everyone will make it, unfortunately. It's important to talk about this. So we will go into mortality as well. And when we look at the count, there were, in this most recent data just last year, there were 660 Colorado residents that died from breast cancer. And the number, however, overall has been increasing for the most part since 2000. Now, there are a number of reasons for that. We do have a bit of an aging population. We also have a larger influx of people moving in. So the population to choose from is also just getting larger, among other reasons. So what we do here is we look at that age-adjusted rate to get a better sense of exactly what we're experiencing. And here we would see 10 people per 100,000 passed away from breast cancer last year. And the rate is overall decreasing, which is a good thing. Although it's harder to tell in some of the more rural environments where the numbers are, the people are fewer. So we're back to this roller coaster. And same thing, 13 per 100,000 people passed away in 2000, down to our low of 9 people in 2019. But then we jump back up again 2020. It's a bit of a strange time, to be sure. And here's where we'll spend the bulk of our conversation. So we've talked about how many people are diagnosed, how many people survive, and how many people unfortunately do not. But now we're going to go a little bit further back in the preventive area. We'll talk at a high level and bring it down to a more narrow view. So to start, we're going to look at look at the recommendation from the United Service Preventive Services Task Force, or USPSTF. They changed the recommendations by lowering the screening age April before last, from age 50 down to age 40. I'll also take a quick pause here to recognize that there are other cancer screening guidance bodies, such as the American College of Obstetricians and Gynecologists. You can look at the American Cancer Society, among others. For today, we're just going to look at USPSTF. Now, with this comes grades. And in this case, the B grade, as you can read here, it's high certainty or moderate benefit, among other areas. So this is saying this is good. This recommendation, we stand behind this, and we feel confident that this is going to produce some good results. But it also received 2 I grades, saying that, well, we don't really know if this age change is going to benefit women over 75 years of age. And we also don't know if it'll benefit women with dense breast tissue. Now that stands out, so I wanted to build out a little bit more context for it. So for those who haven't seen a mammogram in person or online, you'll know what you would see is that for dense tissue, it would show up as white on the scan. Unfortunately, the tumors also appear white. So if you have enough dense tissue, it can quite literally hide any of the cancers that are there. So that's one complicating factor. Another is it is linked, having dense tissue is linked to higher case counts, but it is not, at least tissue density alone, is not linked to higher death rates. Um, and because of these and other issues, there's no full national consensus for how to, for the recommendation that we want to make for those with dense breast tissue. There were two other things they changed in 2024. There was a more a more deliberate focus on health equity overall. And one of the ways they've done that was their second piece you see here. Traditionally, we would rely on randomized controlled trials, and they decided that basically there was a level of bias that just wasn't acceptable. So we started using other study evidence like statistical modeling to make their recommendation, to base the recommendations on. And based on all of this, about 5 months later, the FDA came in and made a requirement. So if you receive a mammogram report, there will be a space on there that will tell you your tissue density status. And you can use that to speak with your healthcare provider to figure out what you should do, whether you need to have an additional screening or what have you. So that is where we pick up for the work that I tend to do. Because we would hope that whatever your activities are, if you are able to answer a survey about it and let us know, then we can talk about what's happening in Colorado as a whole. And to do that, we use the behavioral risk factor surveillance system. There's plenty to talk about with what this is. I will save that. If there are questions and answers, I can answer that a little later. But it is a nationwide survey that just collects health information. That's self-reported. That's the short of it. We're also going to move away from the hard counts of number of medical records, for example. Now we're looking at estimates. So if you think of this, it's more of just where the true number, the exact number that's happening in your population is within a range. And so you think of that as like kind of like your best guess, but you're using statistical tools to get there. And we put it in, we decided to look at cancer screening in 3 buckets. First one being on time, so within the last 2 years. So you can look at this and say, among those ages 40 to 74, 72% have had an on-time screening. And with this younger age group that is now within our recommendations, among those aged 40 to 49, 59% of this group has had an on-time mammogram screening. So the quick caveat is, yes, this number looks a bit low, and well, it kind of is, but that accounts for it not being a full-on recommendation for just over a year plus. So we're not really there. So I look back at the last years that we had, it's a 2-year cycle, and it was at 56%. And all indicators are suggesting that this number will continue to increase until it matches the group as a whole. So that's a good thing. The second category we look at is late. These are for people who have received a mammogram, but it's been outside that 2-year range we want to see. And we want this number to be low. And so you can see how this one reads at 17% for the group as a whole and 15% for ages 40 to 49. That is down from 2022. And again, indicators say this is going to continue to lower, and that's good. I'll take this time also to point out, you'll see the double asterisks here and there. This is just the statistics part of it, showing there's a significant difference, in this case, between the time-based estimate. So we're just seeing between on time, late, or never, which is our next category. Is there a significant difference? And here, we're looking at those who were never screened. That means despite being eligible for mammogram, we have not had. And what we see is 11% for the group as a whole, higher for those who are 40 to 49, not really a surprise. And from 2029, it's actually down 3%, which is a good thing. From here, we're going to look at different groups and communities in categories. So we'll start by looking at age. Now, this question is slightly different. This asks if you have ever received a mammogram at any given point. The group as a whole says 89% said yes. 40 to 49, this younger group, 74%. But what I found really interesting is those that are ages 18 to 39, they're outside the recommendation. And last year, 18% have had a mammogram. And it's been decreasing for the last 2 cycles, so by 1%. So that is something I would love to delve into it. The way you can read this one is about smoking. So if you're going left to right, you could say among those who are non-smokers, 75% have had an on-time screening. 16% have had a late screening, and 10% have never been screened. So that is one measure. And you compare that to the state as a whole. And if you look at the one below, you're also comparing this estimate to the state, not to non-smokers. So you would say among those who smoke, 53% have had an on-time screening, 27% are late, and 20% have never been screened. And this is also a good time to point out that BRFSS is just kind of a point in time. It's not showing you what caused something to happen, only that this was the case when they received the phone call and took the survey. So, for example, someone is a smoker now, we don't know if they were a smoker before or after the mammogram. We can't really say using this data. But it is an indicator that our programs would take on and say, well, we need to find out what's going on with this community because, or those folks, because in this case, that is much lower. So let's figure out the why behind it. Similarly, you'll see this with those who have insurance or those who don't. And you can see for those who are uninsured, these are really low on time rates and really high late and never screen rates, our estimates, excuse me. And this is where we would hand it over to a program and say, hey, insurance is wildly important. We have to delve into this and figure out what we can do to make sure that those who are uninsured become insured, and so that they get closer to the state estimate. Our next group, we look at the federal poverty level. And if you are above this level, or you're above late, excuse me, you're on time, late, and never screened, match the state pretty well. But those who are at or below this level, it's significantly lower or different, excuse me. And I do like to point this out as well. There is a line that is drawn right at the 250% space. This is when a lot of federal systems will kick in. But I want to acknowledge that if you make 251% of this level, you're probably still struggling. There is not just, it's not magic. It's truly relative. But we do see this relationship between poverty and screenings. Again, we need to figure out the why behind it and what do we do about it. When we look at geographic communities, we are seeing a lot of the same, where those who live in urban environments match the state estimate as a whole. Those who live in rural or rural resort areas, lower on time, higher late, and higher never. But you'll notice there's no asterisk here. And that's because it was not a statistically significant difference. But that alone is not enough to write it all off. These numbers are consistent, and you just take in other data sources, and you find maybe this is clinically meaningful or otherwise meaningful. So we don't want to just say, statistically, we are not supposed to care about it. There is a lot more information that goes into this. This one can be a bit complicated to look through, so I'm just going to make some quick takeaways, also being mindful of our time. You'll note that as people progress further in their academic journey, the estimate of on-time screenings also increases. The inverse is also true. Those who are considered late or those who have never been screened, that is also tied to lower education levels. And what's interesting is for being screened on time and being screened late, those who are college graduates or more, that's these blue boxes. It appears protective at this point. And the never screens, it's close to the state estimate. But this is quite interesting as far as the educational piece. Moving on to those who do or do not have a primary healthcare provider. Again, it's a lot of the same, but look at the difference between these two. If you have a provider, your on-time rate, again, match the state. But if you don't, you're less than a third of this group has had an on-time screening. So what we see is another clear relationship, but the question is why? Does it have to do with that being an initial point of contact? Are there referrals that aren't happening? Is it tied to insurance? These are questions that we can continue to ask so we can help this population. Another one to point out here is going to look at both race and ethnicity. I don't love the way this category is delineated, but this was how the data were available to us. That there's a lot more nuance and detail that I would love to provide. But for what we have, I want to present to you. And just as a reminder, in the lower left-hand side of your screen, you'll see the state estimates, and every group is compared to that, not to one another, and that's important. So just going in alphabetical order, those who identify as Black or not Hispanic, among this group, 70% of them, of this population has had an on-time mammogram at 70%. So that's pretty close to the state. Those who were late or never screened, it's kind of hard to tell. These are their numbers, but the estimates aren't super stable, which means I wouldn't rely on them too heavily. Chances are there was a low response count, so not enough people were answering this question to say with a high degree of certainty, this is exactly where it is. So take it with a grain of salt. And those who identify as Hispanic, those who are late, 19% of this population has had a late with getting mammograms, and that matches the state. Those who were never screened also not super stable, so be careful with it. However, the on-time rate is 65%, and this one was statistically significant. And this highlights likely a disparity, possibly an inequity as well. And what we see here is a category I do not love. It's just multiracial or other race only. It's basically saying everyone who's not captured in the top three by size. But it's what we have for now. And what we're showing is the on-time rate estimate matches the state. The late and never estimates are also pretty shaky. And rounding us out, this shouldn't be too much of a surprise. Those who are identifying as white and non-Hispanic are the majority group in the state just by numbers. And so the numbers here match pretty closely to what we are finding in our state estimate. And as mentioned earlier, thank you again for this, Tiffany, was that I work with the Women's Wellness Connection, and one of the focuses we have are on the populations that are not traditionally reached or have a harder time reaching them, or they're marginalized in some way. So they're referred to as our populations of focus. I think the CDC and a lot of our grant documentation calls them our priority populations. So we compared each of those groups to the state estimate, and this is what we have. And a quick way to look through this, just here you can choose a group. So I'll take uninsured. Among those who are uninsured, 35.5% of this group has had an on-time breast cancer screening. So that's how you can look at this information. The state estimate is the orange bar at the top. Now, most of what I've given you here is readily available, and I'm going to show you now how to access it. There's a site that we have here. You can follow this link. The Colorado Health Information Dataset, often called COHID. This is a landing page that has, I want to say, 21 of these green tiles. And each one opens up a different dashboard and web page. And there's a wealth of information. But just staying specific to cancer, these are the three you'll want to focus on. The yellow circle around the word deaths, this tile has all the deaths that occur in Colorado, and there are special carve-outs for cancer deaths. Over to the right of that is cancer incidence. This is the information you saw at the early part, the counts, the age-adjusted rates, and more. And in the lower left side, you'll see chronic disease circle. This is where you'll find the majority of your screening data. And when you open this up in these others, if you're finding that this is good, but this is not exactly what I'm looking for, we also have a data request system. And here's the link for that. Feel free to fill these out, submit it, and someone like myself or another will be able to build you something custom. As long as the data are available, we will be able to get that to you. And that really wraps us up here. So I know there was a lot coming at you. Feel free to watch this again or contact me, and I'm happy to go through everything that we found here. Thank you very much for your time. And I will open it up to the group.
Yeah, anybody have questions for Dennis?
All right,
Um,
Cheryl,
oh, go ahead,
looks like.
Cheryl.
Hi, Dennis. Yes, thank you.
Hello,
Hi, Dennis. Can you hear me okay?
I can. Hello.
Wonderful. Thank you for an incredibly informative presentation. I really appreciate that. I did have one question. I think I
Of
missed
course.
it. It was back when you were talking about dense breast, and that is correlated
Hmm,
to higher case count, but not to
hmm,
higher mortality. Is that because the
right.
long-term data isn't in yet, or is there
Hmm.
statistically significant evidence-based data showing that there isn't an increase?
That one, I did not see them pull the full tie in the documentation that I looked at through the USPSTF. There may be something that I would tell you that it's either just a statistical observation, but my gut tells me this just has to do with making sure that we have all the right information on hand to say that
That's what I
having
thought. Yeah.
tissue equals or is directly associated with higher mortality. I haven't seen anything to fully support that. Though we
Great.
have a lot of well versed folks on this call. If somebody else has more information, feel free. Please update me because I'm here to learn just as much as anyone else. So
Thanks,
if someone
Dennis.
else has it, oh,
That's what I thought too, but then I thought maybe I missed it. So thank you so much. Great
no.
presentation.
Oh, I appreciate it. Thanks so much.
This is Jan Lowry again.
Hi.
I would imagine the registry doesn't have it, like you said,
Mm,
consistently yet, in order to give us stable estimates. But I don't know, maybe more data are coming. I have a comment and a question. Thank you, Dennis. This is
of
very
course.
informational. So I struggle a little bit. I know you explained it early on with including men in the denominator.
Mm, right.
Because it can be really misleading. I mean, men are not, the incidence rates for male breast cancer is so
So
low.
low. Very
Men are
low.
not, with very, very few exceptions, recommended to get screened. So I don't know. I kind of struggle. I personally like it more, among women. Here's the breast cancer rates. It's
Right.
more comparable to what's typically reported nationally. And it so kind of gives us these other benchmarks. But I
Okay.
understand why you do it. I don't know how that works with the influx of younger males to color. I don't know. I mean, I know they're age adjusted, but I mean, it's just something to think about.
No, of
Um,
course.
and the other thing is that it's not really consistent with Burfess. So I'm assuming for Burfess, your denominators that you presented are all women.
Correct.
Okay. Um, and this 18 to 39-year-olds who are reporting mammograms is, well, first of all, it's interesting. But I guess it means you're asking 18-year-olds if they've had a mammogram. So,
Correct.
so I'm wondering if that's true, if your estimates for looking at stratification by insurance, smoking, education, what is your denominator? Is it all women
Hmm.
or is it women 40
No.
plus or because that might
Ah,
be a way to maybe explain some of these findings that we're having, why maybe younger women are, I don't know about smoking, but around education, of course, they haven't had enough time to attain that education. They also might be uninsured. So just something to think about.
no. All excellent points. And I thank you for those because you're absolutely correct in everything you've stated. I will say that for the including men in the denominator, I'll start by talking about incidence and mortality. Those numbers do include men. The, the good news from a statistical standpoint, like you said, that the numbers are few and far between. So the shift between one value and another, we're looking at maybe a tenth at best. So it's not going to be too inaccurate. I would look to see if there were higher counts as we age and see if we need to completely diverge them, divest them from that group. I would say incidence mortality, I believe, captured them. I can easily rerun that and it takes no time. And in fact, we can all look at that if we go to COHID. You do have the option to deselect men from males from that population. And like I said, the numbers really aren't that different than taking out somebody that's age 0 to 4. Like they're very, very low. So I
Right.
don't think there's too much of a difference there. That said, when we look at Burfus, typically the way that we'll look at the calculated estimates, the ones that Burfus does all by itself from the CDC, those specify the population as females ages 40 to 74 for most of the questions. The one that stands out is the one that asks if you've ever had a mammogram. It's truly just the yes no of just that, the descriptive statistics. That asked it of 18 to 39-year-olds, which normally you wouldn't. I was surprised by it myself. I didn't think they would have any, maybe one person, but to see enough that you would see a drop between 2020, 2022, and 2024 was surprising, and I can't wait to delve into why that's even being asked. That said, every other value that we looked at, all the demographic groups, are only looking at those that are age 40 to 74. The only time we looked at 18 to 39 was for that single question. But I just wanted to clarify that. I'm glad you brought that up.
Yeah, no, that's super helpful.
I think the 18 to 39-year-olds may have been symptomatic or had family history or high risk. There are many reasons to.
Yeah, the question is why, and unfortunately, Purpose doesn't answer the why.
Yeah,
It just
but
says that
I think there are plenty of reasons why 18 to 39-year-olds would have a mammogram that's not just like getting a mammogram for fun. Like that they needed it due to symptoms, due to family history, due to risk, that kind of thing. But
Yeah,
It's
it's a lot
interesting.
though, Emily. It's like 18%.
Yeah.
A lot.
I know
That is
it is
huge.
interesting.
Yeah, and to your point though, if we're talking about a denominator of women 40 to 74, why would we even ask the younger ages of this group? Like, why would we include them at this point? I honestly couldn't tell you why. That is a different question that would have to go up through coordinators and national folks. That is beyond my pay grade, frankly. But it was curious to see it there. I'm with you. But thank you for bringing that up. Floor is still open if you'd like.
Denise, great presentation. This is Virginia. Thank you so much for your time
Hello.
and the
It's good to
data
see you.
presentation. It was phenomenal. I was really mesmerized by the information about the counties. You mentioned that Jefferson, Arapahoe, El Paso, and Denver had the
These are
major concentration of individuals with breast cancer or women with breast cancer. Could you talk a little bit more about that, please? Did you survey the 64 counties in Colorado?
Yes, and in fact, you can do this as well. I tried my best to make sure that most everything that I present is, I don't want to say commercially available because we're not selling it, but it is available to the public. It's public facing. That COHED website, if you opened up cancer incidence and you go for the most recent data, the first thing you'll see there is a map. And when you pull up that map, it will show you the highs and lows and who's where. It'll have case counts, crude rates, and the age-adjusted rates. So when we looked at it, the age-adjusted rates, those four lit up. And of course, they're right along the Front Range. But this is something I've seen in other cancers as well, is that I think it was colorectal cancer most recently, where there were four counties that accounted for almost half, and it was three of those four as well. So what's going on in those areas? Two, what's happening outside those areas? And three, how well are we measuring other areas? So we talked about the rural and rural resort areas being more of a challenge because if you have too few people, numbers become suppressed, the data are unstable. What do you do in those cases? And it's kind of hard to tell. But when you have a case count, it's right there. And I think their suppression rule is something like 3 people. So if you have more than 3, you're counted here. And so, yeah, I honestly could not tell you why these cases are happening in such concentration in those 4 counties. There are a number of potential reasons. Maybe this has to do with access to getting screening. If you're in an area that doesn't have one, forewarned is forearmed. In this case, you're not armed. You don't have this information. You end up being more likely to have you end up more likely to be late screened or have a later stage of diagnosis if you aren't close to a place that can actually give you a screening. If insurance is keeping people away from a place, that could be another problem. There are multiple inputs that could contribute to that, but right now the answer is we do not know. This, at least as far as this is concerned, but this is where programs like WWC help out really, really well, and they are part of their task is looking for populations that are more difficult to reach, people that need our help in getting breast and cervical cancer screenings. Oh, thank you for putting that in there. That is absolutely wonderful. This is another great website that you can look at, or dashboard that you can look at and see a lot of this information, plus stuff I have not covered. This is an excellent resource, so I would highly recommend this as well. So I think some of the questions you are thinking about as far as virality will also be answered in here. So please check them both out.
Thank you kindly. Thank you so very much. It made me think anecdotally because I've been working with some mental health campaigns, and we noticed something similar when it comes to the most cases being reported from Jefferson County, although we've been working with 4 campaigns statewide. So it's just anecdotally, but thank you. Thank you again.
No, it's important. And that's what makes, in a kind of gallows humor way, it makes this job exciting. We want to figure out why things are the way they are. First thing we have to do is identify them. Then we measure, and then we can go into the rest of the work. But yeah, that is a little odd. Are we seeing something where it's environmental? Probably not, but we also can't exactly say for certain. It absolutely is not. So these are things we have to look at. Are we dealing with clusters of families? Who's to say? But that's the next step.
They're also like, for the most highly populated, is that you already said that in the state?
Yeah,
so I think you're just going to see there's just sheer numbers. You're just going to see, because what I put in here, the Echo platform is a lot like what you have, Dennis. And the cautionary tale I always have is the rates are higher in some rural counties, but the numbers could be really quite small and highly variable for reasons you described, Dennis, quite well, that the numbers are just small, so very unstable estimates. So it's always good to have the rate, but also the number,
right?
The sheer number of cases.
Absolutely. And this is one of the reasons that we'll say, I live, eat, and breathe BRFSS. This is just one of the big areas that I work in. But I will never rely on any one single source. You really want to pull in as many different data sources as you can, but you also want to pull in qualitative as well. So want to have informant interviews. If you are able to talk to a focus group, find out more about what's happening on the group. You'll always hear me talk about data and stories. You really want both. You can't just have one without the other to truly understand a population.
So I'm just sorry to talk all the time. I'm just new. I just joined the task force. I've been aware of the task force for many years, but has the task force ever gone to BRFS and added any questions or asked to add any questions, like on what are the barriers to you getting screened or reasons why you're not getting screened, anything of that nature?
I would wager they wouldn't ask questions about why, because just the design of BRFS wouldn't really tell you why. It's just going to tell you that it's linked to something else. It's cross-sectional, so we can't really get into the because. However, we can do other data sources, different white papers, pulling in different programs and other EPs like myself, to kind of put those puzzle pieces together to figure out where the problems actually lie. But BRFS in and of itself wouldn't give you the why, it's just telling you that it's happening. And actually, I work with Emily to do that quite a bit. I think every year we have some conversation. Are the things in BRFS that we'd like to add, change? And what would you like to do with that? What is it that we would like to know? And so this is a conversation we do tend to have at least annually. And feel free if you want to add to this. It's an excellent point.